So varicocele, it's basically dilated veins of your testicles, of your scrotum. So the same way we get varicose veins of our legs, these are varicose veins of the testicles. Some of the reason why it's of a concern is because it negatively impacts testicular function.
This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin.
All right, so we're back here at the AUA. It's an annual urology conference, and we're here with another live episode. This week's episode is titled You're So Vain. We're going to talk all about varicoceles with Dr. Justin Houman, who's a good friend of ours. Dr. Houman, why don't you give a quick introduction to our listeners?
Well, thanks for having me, guys. So I'm Justin Houman. I do what you guys do. I practice sexual medicine and men's health at Tower Urology at Cedars-Sinai, so in Los Angeles.
All right, dude. And we've known each other for a while, going back for many years now.
Many years.
Fantastic urologist, fantastic specialist in men's health and infertility. So today we're going to be talking about varicoceles. So let's start off very generally. Like, what is a varicocele?
So varicocele, I mean, we see it. For us, we see it quite often. I think for the layman, it's very rare for them to see it or to know what it is. But it's basically dilated veins of your testicles, of your scrotum. So the same way we get varicose veins of our legs, these are varicose veins of the testicles. And the reason why it's bothersome, or the reason why it's of a concern, is because it negatively impacts testicular function.
Okay. Now, the way that I look at it, the varicocele, is kind of how arteries have muscles. They bring blood to an organ or wherever it may be, in this case, the testicle, and then veins have these like valves that prevent the backflow. And like varicose veins of your legs, right, you're going against gravity. So this idea that, if you have these valves that are dysfunctional, they just kind of backflow because they just can't go, and you have this dilation. But it is somewhat concerning, right? But the thing that's also interesting here is that people don't know if they have them, right? Kind of what you're saying. So the question then becomes, how common are varicoceles?
Way more common than you think. So I generally say about 1 in 6 guys. So about 15% of guys have this without even knowing it. And majority of the time, at least for us, when we see it, it's one of the main causes, the easiest fixable cause of infertility, because it does cause significant fertility issues for men who are trying to conceive.
Now, varicoceles, they're more commonly found on the left side. Why is that?
Yeah, so to your point about the veins, the valves malfunctioning. So the veins, basically, they have a difficult time. With a varicocele, the veins are unable to drain the blood back to the heart. Blood pools around the testicle. And on the left side, we see it primarily because the way the left testicle, that vein drains back into the body, it hits it at a right angle. And that right angle creates back pressure. So 90% of the time, we see varicose veins on the left side. The right side, the transition for the blood back into the heart, it's a nice, smooth transition. It's not that right angle. So it doesn't build up that back pressure. It's one of these interesting things about the way we've evolved, that it's a quite faulty mechanism, but so far we've evolved to this point that we're still able to conceive, and now that we know about it, we're able to fix it. But quite faulty mechanism.
Yeah. So how do you diagnose a varicocele? Because I think oftentimes some people come in, they're worried about a varicocele. Some people say that my primary told me I have a varicocele. How are you diagnosing varicoceles?
Primarily by physical exam. So a guy will come in. Either he has infertility, so he'll come in with a semen analysis and his sperm counts are low, one of the sperm parameters are off, and then we'll do a physical exam, do a blood test. But the physical exam, where they bear down, they take a deep breath, they bear down, you're able to really palpate this bag of worms type thing, where this swelling in the spermatic cord, or the cord above the testicle, you're able to feel that swelling. For me at least, I'll do a physical exam. In some cases, I'll order an ultrasound, a scrotal ultrasound. I don't know if you guys do, but I'll order a scrotal ultrasound just to confirm sometimes. But really, it's as simple as a physical exam.
What do you think, Kevin? What do you do?
Yeah, it's the physical exam. I tell my, the guys are like, hey, doc, you're not really touching my nut. You're touching above it. I'm like, well, there's a reason. I'm not just like hanging out and just having a good time. No, but yeah, mainly for me, it's like physical exam because I'm really looking for those like really clinically ones that are really apparent, But I do, scrotal ultrasounds can identify some of these more minor ones, especially if they're having like pain or something like that. How about you?
Yeah. I mostly it's the physical, and the thing is with varicoceles, because of the physical, it's a pretty subjective evaluation.
Sure,
right?
that's excellent. Right.
You really have to see a lot of varicoceles to know what you're doing, because I don't know if you want to break down the grading system at least, so our listeners can understand, because sometimes I'll be like, oh, this is a grade 2, maybe a 3. I don't really know. And, the ultrasound can help, but even an ultrasound can be subjective, right? Because the ultrasound tech has to be good. They have to tell them that they're valsalvaing appropriately.
Yes. Oh, yeah.
So there's so many different factors in assessing whether someone has a true varicocele. Obviously, as you'll describe the grades, a real grade 3 bag of worms, anyone's going to know.
You don't have to touch them. You see
Right.
it.
But that's not everyone.
Right.
So how do you grade varicoceles?
So really, it's 1, 2, 3, mild, moderate, and severe. To your point, the 3s, I think we all know.
Yeah.
You could just see it. You don't have to touch it. The 2s, you're able to, for the most part, you have a good sense of how it feels. It's the the 0s or the 1s. That's the ones where sometimes these guys have thick cords. They have thicker cords.
Yeah.
And like
Oh, yeah.
it's a fatty cord, and you're trying to feel the vein, but there's a lot of fat in there. It's like lipoma. You're like, I feel it. I think I feel it, but I don't know if I do. And those are the ones where I get the ultrasound just to confirm.
Yeah, I think that's incredibly reasonable too.
Or even sometimes into like where it's just like a slightly retractile like testis, or like a little bit more meatball-y, where it's like very difficult to like kind of get to spermatic cords. Those ones I really
get to pull it down when these testicles are exactly very retracted. And these guys get nervous right during the exam, so they tighten up everything. Like, help me, man. Help me help you. Help me out here.
So, I mean, I think the big importance, though, is you have the clinical versus non-clinically significant varicocele, right? Grade 2 and 3, 2 being you can just feel it without them bearing down. 3 is you can see it, like you said, is what we consider a clinically significant varicocele. And there's obviously discussion now amongst the literature and data of how people are going to be treating that, which we'll talk about later. But grade 1 is when you're bearing down and you can feel it, which is hard. That's the hardest one to really identify. Some people, we call that clinically insignificant or non-clinically significant varicocele, for sure.
Right. Now, Dr. Houman, you kind of touched on it about varicoceles and their potential impact on male fertility. So why don't you kind of tell our listeners like what that association is? Yeah.
So the way I break it down is the testicles are very temperature sensitive. They like to live in this narrow temperature range, and the scrotum is like a thermostat. So it really helps keep the testicles within that narrow temperature range, contracts and relaxes based on the temperature. When blood pools around the testicle as a result of the faulty veins, the testicular temperature is elevated. And as a result of that, it causes a couple things. So I always say there's 4 things that it could cause. Infertility, and I'll come back to that one. Testicular pain, testicular atrophy in terms of smaller size. And then I also tell guys about testosterone, the negative impact it can have on testosterone. Where some guys, they have no other reason that they have low T, right? No other reason other than they have a varicocele. And it's one thing that I offer them, hey, listen, if you have low T and you have a varicocele, we can get an improvement. But to answer your question about fertility, anytime you have increased testicular temperatures, the sperm, sometimes the concentration, the count, the way they look, the way they move, all of those motility, morphology can be impacted. But more importantly, the DNA, the quality of the DNA gets increased oxidative stress, and it really negatively impacts the quality of the DNA, which could significantly impact fertility for some couples.
Yeah, I mean, I think that the DNA part's also very important, because I think we've really started to understand that a lot better in the last 5-10 years, right? Where this idea of DNA fragmentation, the sperm is safe inside the testicle. It has the testis blood barrier. The 2 powerful brains, your testicle and your brain, have these blood barriers, right? We're going to control our survival through those 2 things. And when they go out to mature in the epididymis, that they're not protected anymore. And while the sperm has normal DNA, that varicocele and the negative environment of that pooled old blood, the temperature, reactive oxygen species, damage that DNA, so that even if it can make it to the egg and start the fertilization process, it doesn't complete it.
Exactly. That's why you get the miscarriages.
Right, you get recurrent pregnancy loss, and that's something that we're starting to see a lot more. I think we can all agree in the last 5 years, definitely treating way more varicoceles for recurrent pregnancy loss or failure to progress in IVF than I have seen even during training.
And at least in Los Angeles, I can tell you, I think part of that, I agree with you, but part of that is these REIs are much more, they understand the impact of a varicocele and what could be done.
Great point.
So from their end, because they're the ones who really drive the ship.
Right. Yeah, that's a good point. So the other thing I did want to mention statistically, right, when we're talking about fertility, you said 15% of men have varicoceles, but guys who come for fertility issues or have infertility, it's about 40% of men have varicoceles. So this is a statistically significantly large group of people who are coming for fertility who need to go get the exam, right? A lot of the times, these are the patients that most of the time I can do telemedicine on a majority, a lot of patients. But for fertility, it is essential you really get the exam. And that's one thing I wanted to stress here today is, you can see me at first if you want to just get an intro, telemedicine, whatever, but I need to do the exam to make sure you don't have a varicocele, check your testicle size.
Yeah, I've tried the testicles in the webcam. It just doesn't really.
Just put them real close and bear down.
It just doesn't replicate.
So the other thing you mentioned, which I think is becoming more interesting, is this idea of varicoceles and its impact on testosterone. Tell us more about that.
So, I think we all like the idea of testosterone. Even young men these days are trying to optimize their hormone levels. And we know that there's a couple causes of low T. Sometimes your testicles just aren't getting enough signal for having, and we could fix that with medications. But, I actually try to really be good about this in terms of doing a physical exam on these guys who come in with low T to see if they have a varicocele. Because to the point of, the blood pooling around the testicle impacts testicular function, it could really decrease the amount of normal testosterone they're producing. So I say 100 points. I don't know what you guys quote, that you could possibly improve your testosterone by about 100 points, especially if these guys don't want to be on Clomid, they don't want to be on injections, they don't want to be on any of these things long term. It's like a fixable reason to fix their correct their testosterone levels for young men.
So I'm going to ask all you guys now: is there a grade cutoff for you guys for whenever you're counseling guys about, hey, maybe this grade varicocele could help potentially fix you?
So I think there's a lot of controversy on this because I think traditionally the answer was, when I was saying clinically versus non-clinically significant, was treat 2 and 3.
Right.
You don't do anything for 1. But a lot of people have been treating 1, and I feel like there's been some data suggesting that it works. So I think it's really like medicine. There's an art to it. You have to see what the indication is. You have to see, we didn't even talk about pain yet, which we will, but I typically don't treat pain with a grade 1 most of the time. I don't think, unless I'm really convinced it's a significant one. And we'll talk about pain, but it has the pain profile. If it has to be significantly strong to the symptoms of a varicocele, right? I'm not just because I'd rather do a cord denervation or something like that. If I think it's another version of testicle pain, I'm going to do the other surgery.
Right.
It's not, which includes varicocele.
Exactly.
Anyway. So your point is you're doing it anyway. But yeah, no, I think there's an indication. So I just had a self-realization of this thing. So I guess I am treating it no matter what. Fuck, dude. So yeah, I guess I just shot myself in the foot there. But yeah, what do you think?
I anytime, to me, if it's your point about it being an art, if there's nothing else to do and they're struggling with fertility, I'm going to offer it to them. You've optimized their hormones. Their wife looks good. Everything looks good across the board, but they have this grade 1, grade 1 varicocele. Look, you could either keep trying, right?
Yeah.
Keep trying for another couple of years, or we could just fix this in the next 3-4 months. You'll notice some kind of improvement in your sperm counts. Fingers crossed. But if everything else is fine and this is the only thing, I offer it to them. And I
think that's reasonable.
I'd recommend it. At that point, I'd say, hey, listen, let's do this.
Yeah. No, I hear you there. I hear that. What do you?
Just like you guys said, it's very shared decision making, right? I really throw the data out there and I tell the patients, look, grade 1 could be controversial, but just like you said, you guys have been trying, you guys want to do it naturally, and it just hasn't been happening. You want to take this variable out? we can get it taken care of.
Yeah, I think it also depends on what your goals are here, right? Because a lot of these fertility patients, if the partner is like 40 years old and they have to go through IVF and maybe it's a grade 1, they haven't even tried yet, like, do you need to fix it? Do you want to delay the time for them
Sure.
to go through the IVF process? Or if they have a severe oligo or just low sperm, or that you don't think, they probably have to do IVF either way, and they're not going to be able to achieve IUI goals. You know, it's kind of like delaying things. So you have to have a conversation with the couple and see what their goals are, how they want to, how to go with it. But I don't think that there's a wrong answer. Is
No,
the point.
no.
There's no wrong answer here.
No.
So let's go to testicle pain. So how, like, what does testicle pain sound like if you have a varicocele, or feel like?
Yeah, so and this is, testicular pain, for better or for worse. I think we all see a lot of it.
Oh, yeah.
Lot
Yeah,
of.
yeah. Which, to be honest with you, I actually, as weird as
I
it
like
sounds,
it.
I like it as well.
like it
I like
too.
it as well because it's pretty.
The algorithm's
algorithmic.
good.
Yeah, exactly. It's algorithmic, But so sometimes they have testicular pain, like chronic orcalgia, just from having testicular pain in the nerves, and they have varicocele pain, or they have both. But pure varicocele pain, at least the way I describe it, is. It's a type of pain that it's like a dull, achy pain that really gets worse throughout the course of the day. Like the way I try to rationalize it for them is blood, when you're standing up, blood's pooling around the testicles, gravity's pulling it down, making that pain a lot worse. When you lay down in the morning, or when you lay down after a nap or something, you'll wake up, you'll be like, well, that pain's pretty much gone because the blood has worked its way back into the body, or it's not pulling down. But anyways, chronic dull pain that gets worse throughout the day. That's really how I describe it.
The exact same way that I describe it.
Yeah,
Just-
laying down makes it better.
Yes.
And and that's kind of that's it. And that's the signal that it's a true varicocele pain. Full disclosure, I had testicle pain. I had varicocele. I had varicoceles. I had varicocelectomy bilaterally.
Wow. You do an ultrasound before you did it?
I did.
Nice.
This was a long time ago. This
Was
was
it,
2010.
was it grade 3?
I don't honestly. I'd never looked back. I have no idea. I was like 22 years old,
Gotcha.
but I'm not paying anymore.
That's why your testosterone levels are so high
Yeah,
now.
that's probably, that's true. That's true. Oh shit, man! I'm just having a lot of realizations right now, dude.
So, Dr. Houman, our listeners are like listening now, and they're like, "Oh man, so varicoceles, fertility, could cause pain. Is there a specific time that someone should go get checked for a varicocele?"
I would say, so yes, I would say just the earlier the better. If you're having pain, definitely see a urologist, because we could all agree with this. I don't think primary care doctors really have a good sense of how to, when it comes to testicular pain.
Yeah.
So see a urologist if you're having testicular pain. See a urologist if you're having infertility, because those two things, whether it's testicular pain or infertility, a varicocele could be the culprit.
Yep.
And the earlier you address it, the better, because what we're saying, it takes about, at least from a fertility standpoint, it takes about 3-4 months to notice a benefit from your sperm count, sperm quality. So the earlier you do it, the better.
Yeah, and I also think that just talking with a urologist in general is never a bad idea, right? We cover so many things: hormone optimization, erectile dysfunction. This is just part of the exam, and I also think that sometimes kids identify it when they're younger, and then they just never think about it again, right? Because this is something that usually shows up around puberty. And so maybe they were seen by a primary care, and we often see guys like we all say, it's like, oh yeah, I was told I had a varicocele like 15 years ago, and they just never followed up on it. And it is something to consider, and actively caring about your health, showing interest in your health, can maybe save you some time, some struggle.
Yeah.
So I think there's something there.
Yeah, for infertility, I mean, a guy should really be proactive about
Absolutely.
infertility. He has to be, because the IVF doctors, they do great, but they only know the female side. Like, you shouldn't keep doing IVF cycle after IVF. If you're failing at one or two, even one IVF cycle, just see one of us.
Absolutely, that's such an important point. Not enough people are seeing on a urologist.
Yeah, I see couples failing 5 times, 6 times before they see a urologist. I'm just scratching my head. The earlier
Guys, DFI is through the roof with a grade 3 varicocele, and so we
takes 2 to tango. 2 to tango, right?
2 to
So you
tango,
gotta get that male side checked out. Now, all right, so you've done a great job talking about exactly varicoceles, what they are, what they can cause. So, let's say you've been diagnosed with one. What's next? Should I be worried? Is there something that needs to be done?
Yeah, so there's no medical, or the medication that could fix a varicocele. It's a surgical treatment option, and the gold standard is what we all do. It's the microsurgical varicocelectomy. the subinguinal. The closer we get to the testicle, the easier it is to tie off the veins, and then the recurrence rates are obviously significantly lower, 1%. We also have access to the gubernacular vein, so it makes it easier. That's what I would recommend. I think the three of us agree. All of us, we agree that that's the best option for patients. Sometimes patients choose, or they want to do an embolization if they don't want to go through a surgery, full-on surgery. But in terms of recurrence rates and success, the microsurgical varicocelectomy is the gold standard.
It's one of my favorite surgeries to do, honestly.
Amen.
It's a very
Amen.
satisfying surgery. It's a very cool surgery. Procedure takes an hour, sometimes 45 minutes. Getting you out of the room, you're home the same day. It's a really satisfying surgery. I don't know what you think.
Yeah, I love the surgery, and I also tell guys like, and I don't know if you guys have seen this. So, guys who get when you get your varicocele embolized, and we're doing these in a lot like younger guys, right? Fertility or pain. If you get embolization done, it actually causes artifacts for use in like MRIs later. And MRI prostate's very important for diagnostics and prostate
That's a
cancers.
great point.
Yeah.
I had a guy who was like 50 years or whatever, and we had to get an MRI of his prostate, and they basically we got it, and the read was like not really useful because like the glow coming off the artifacts coming off the embolization makes this like a non-useful diagnostic.
Wow.
So that's kind of what I counsel patients now. I'm like, hey, look, MRI prostate is going to be super important moving forward for any guy.
Yeah.
So just something to think about.
Yeah, I also think that you shouldn't be worried if you have a varicocele, right? Like I know we talked about a lot of things it can do to you, but remember, 15% of the population has them. I would say the majority of people live their whole lives, live normal lives, no issues.
That's a valid point.
And don't know they have a varicocele. They have 3 kids. They come in. How many vasectomies have we done on guys who have just massive varicoceles that they've had kids naturally, right?
Yeah.
Like,
You're like,
holy
God
shit,
damn it."
where's the vas? Dude, you're like, so I it's not something that you need to freak out about. It's nothing necessarily bad that you necessarily need to fix, but that's why you got to talk to the doctor about it, right? You have to go seek counsel and see what's going on.
Yeah, because the surgery itself, I mean, it's not even from a patient standpoint. It's relatively straightforward. 45 minutes or an hour, and it's outpatient.
Yeah, and then relatively low risk. I mean, infection, bleeding, very low risk to the area, the testicle. We use a Doppler, make sure that the testicle artery is identified and preserved. It's a great surgery. It's really
and incredibly successful too.
Yeah.
Yeah.
So we talked about microscopic varicocelectomies. Now, just tell us what the recovery process is for that surgery.
Yeah. So we use a small incision because it's such a small incision. We're not really cutting through muscle. We do it in an outpatient setting. Patients go home the same day. I tell them they're able to walk around that night. Realistically, Tylenol and Advil do it for the patients in terms of pain control. I tell them to take about 2 days off of work, and then really no heavy lifting for about a week or two. But you're really back to normal living after a few days.
Yeah, I mean, how long do you tell them to hold off on sex, Kev?
On sex, I usually just say like about 2 weeks or so.
Yeah, I'm in the same boat with that. What do you say?
Yeah, I say 1 to 2 weeks. Listen to your body. Like some guys want to get involved.
Listen, or they don't listen either way.
It's exactly
That's
right.
the truth.
Actually, I think we
exactly
should take
right.
a moment and, if you don't mind, Justin, sharing that one patient story about that patient message you got. This is actually not related to a varicocele, but related to the vasectomy.
Yeah, so I did a vasectomy on a guy.
This is great.
4 hours later, he messaged me and said, theoretically, if someone were to get a blowjob within 2 hours of having a vasectomy, is that bad? I was like,
Theoretically.
Asking for a friend.
yeah, I was like, well, I would say theoretically you should not be doing that, but sounds like the anesthesia, the local was very good. But yeah, don't do that. Don't do that, please. That's not a good idea. But with the varicocele, so we're in that surgery. We're tying off all the veins, right? We're looking under the microscope. We're tying off all those veins. And then we're now giving the testicle a new environment to live in, right? We don't have that blood flowing around it from the dilated veins. How long do we have to wait now to test whether the varicocele worked?
So
surgery worked?
Yeah, great question. So the precision of it is, I think, one of the things we all like about it. But yeah, we dilate those. I mean, we tie off those dilated veins, peel it off the artery, make sure everything is good and clean. So then we reroute. The blood is being rerouted through some of the other veins in the scrotum to get back to the heart. And over that time, I usually check a semen analysis at 4 months.
I think that's right. Yeah.
We all say about 72 days in order to have for sperm to mature from the beginning to the end.
Mm-hmm.
But I'll say about 4 months just to give them that extra month and a half to recover. And then that's when they see the improvement. I've had patients who've gone out of their way and they've checked like a meat fellow test or at home test at 2 months. And the levels, their sperm counts have gone down. They've gone significantly worse. I'm like, well, listen, you have to give it some time.
Yes.
So it gets worse before it gets better, or at least anecdotally based on that one patient.
I think that makes sense, though, right? Anytime your body undergoes a surgery or some kind of
Stressed
trauma
out a
or
bit.
stress, right?
Yeah.
And higher cortisol levels, inflammation is not favorable to sperm to develop. So I think that 3 months I agree. I think 4 months is the better time to just let them cook for a little bit.
Exactly.
But yeah, I mean, I think the data shows and this is, this is the question, I guess. What are the chances when we're talking about fertility that it's going to improve your sperm count?
I try to say you have about a 50 to 70% improvement in terms of your fertility. Now,
Percent or chance of improvement, or are you saying?
So I'll say you have your sperm counts will improve by about 50 to 70%. But more importantly, and that's kind of a vague number. But more importantly, I'll tell them like your chance of conceiving naturally will double or triple, right? Like 2 times. Like that's the more important thing here, not so much what your sperm counts are, because you're doing this all for the point of conceiving.
Right.
Right. So I'll say you'll double your chances of of naturally conceiving.
Okay.
That's what I say. I don't know what you guys quote.
What do you say?
Well, again, when it comes to the varicocele and it comes to fertility, I do it like in a very nuanced way, right? Like the data shows, your sperm count, I think there's improvement on it. In terms of conception, improvement on it. But again, none of these are guaranteed.
Yeah.
Correct.
That's what I always tell patients at the end of the day, like, hey, just because I fix your varicocele does not mean that you're 100% now going to get pregnant, right? Still so many variables. But I do think that, again, as fertility docs, we can all agree that there's many things we don't still know about, right? And could this varicocele be fixing something that we don't know and that metric gets improved?
That's a great point.
100%, right? Yeah. Again, it's very gray, I think. I don't know how you do it, Justin.
I'm kind of like, I don't, because I think that we always, before the surgery, I like to set the goals, right? If your goal is like, I'm trying to get to IUI level so I don't have to go through IVF because it's cheaper. And
Duman's going to rope in his paper, right?
Yeah. And then, that's the paper I did do. But yeah, we published on it. It worked. So, I think that's the realistic goal. Some people, though, I say in general, there's data that shows, 70% of the time you have improvement, 20% of the time nothing changes, and I think 10% of the time it can actually get worse. And
I always tell my patients, there's a chance we do this,
and it doesn't.
It's not gonna look so great afterwards.
Yeah.
There's a chance.
It's a chance, and we did at Northwestern a study. We tried to predict, see if we could predict who got better or got worse. Looked at so many different grade varicoceles. Couldn't predict anything. Couldn't find a pattern there.
Yeah, and even the grading when it comes to like a grade 1 having
completely
significant
subjective.
impact, yeah, exactly.
Completely subjective.
That's
You're right.
the annoying part. It doesn't correlate at all.
Yeah, but because of the fact that you have that 10% chance of decline, if a patient of mine, and I think we all agree, if they have, in general, the guidelines I think, said like 5 million, or like, I always recommend that consider banking if you're severe oligo,
Sure.
no matter what. Obviously, our goal is to improve it. We've all had guys where we've had severe oligo, did a varicocele, and it went much better. I don't think of a time that anyone went azoospermic or had no sperm, but I tell these guys before I do a varicocelectomy, it's not a bad idea to bank sperm sometimes if they have a very, very low sperm count, because God forbid that 10%. It's there. It exists. But in general, you're going to either be better or at worst stay the same.
Yeah, and then fix your testicular pain as a result
Correct.
of it. Yeah.
Correct.
Yeah. And improve your testosterone.
Yeah.
levels.
What
Some benefits.
What do you tell for testicle pain? What chances do you think of improvement?
About I say 80 to 90%.
Okay.
Yeah, 80 to 90%.
What do you say, Kev?
I usually say around like 60, 50, 60%.
Yeah, I say usually 50, 60. Just, but I think that it is subjective, and I think also it's how you select your patients, right?
Right.
And I think it's, and you know, I do think if you are going to the right person, like you and him and me, who see this all the time, we're not doing a varicocele on testicle pain unless it's a real varicocele that we think we're going to fix and make a difference, right? And so I think it's very reasonable. Like any one of us, we're taking you with testicle pain to get your varicocele done because we think it's going to be better.
Right.
Right. But I think always counseling is like anything. Nothing's guaranteed in life. We can't always fix everything. So, what do you think, Kev?
Yeah, well, last thing I want to kind of bring up and kind of ask is how do you counsel your patients on recurrence?
It's a great question.
On varicoceles. So, like, kind of just tell the listeners, like, talk about recurrence in varicocelectomies and stuff like that. So,
the way we do it with the subinguinal microsurgical approach, I'll say you have a 1 to 2% chance of a recurrence. I go for the gubernacular veins as well.
Yeah, it's a great move. It's a great move.
You have to.
Absolutely.
You have to, because when they embolize it, when the interventional radiologist, they can't get down there.
Exactly.
100%.
Right?
Exactly.
So and to me, that's a big source of recurrence.
Yeah.
That a lot of I do think other urologists, some urologists who aren't fellowship trained who do this, they don't go after the gubernacular. So I think that's one thing that we all do that really helps. And then even if there's like, because when you open up that cord and you see it, like, oh my God, these are like Horkin veins. You know you have to get some of these. But even if there's something that's mild or it's like a small vein, if it's not too close to the artery, or if it's not really attached to the artery, sometimes I'll even go after those
100%.
ones
100%,
to really
right.
minimize the chance of a recurrence. But having said all this, if to me, with our approach, with the microsurgical, the subinguinal approach, like, it's quoted that we say 1 to 2%, but I actually think it could probably be lower than that, because we're really getting everything as close to the testicle, and in doing so, we're doing a great job for these guys.
Now, how do you counsel patients who, because we've all seen this, who you didn't do any surgery on, and they're coming to you because they're seeing you for a recurrence?
Yes, well said. So I'll get their operative report, right? I'll see if, to me, again, it's that gubernacular vein. I'll see if they got the gubernacular. So if another urologist did it, I'll look at the op note, see what they said about it. If they didn't, then we'll do the same approach, go in there, see if there's any veins on the cord itself, and then go after the gubernacular, or more commonly, like an embolization.
Yeah.
If a patient had an embolization, I know they didn't go down there, so we'll go back in there and tie it off.
Yeah. What about you, Kev?
Same thing.
Yeah, I think it really depends on whether they had the microscopic varicocele or the embolization. I think 100%, if they had an embolization, we're going in, right? Sometimes, I talk, the way I was trained is, if they had the varicocelectomy, before, I will consider sending them to embolization, actually.
Yeah.
The other way. So you're kind of covering every aspect of that vein.
Right. When you did it yourself and they have
Right. Yeah. So it's like, because it happens.
It happens.
It happens, right? There is no perfect person out there. So
that gubernacular vein is quite satisfying too. Isn't
it actually is. Can you see it? It's like hooked out. It's just like a big wide one.
Asking for it.
Absolutely, dude. All right, man. This was awesome. This was really informative. This was great. Thank you so much for highlighting varicocele, because honestly, this is an episode that we've wanted to do for a while, and a lot of patients ask about it. So this is really great. You provided some
Thanks
awesome,
for coming on, man.
awesome.
Thanks, guys.
So where can our listeners find you? Tell us about yourself a little bit at the end here.
Yeah, you could look me up anywhere online, Justin Houman MD, social media, website, humanmd.com, but otherwise, any social media platform.
I mean, Justin and I always try to get people to watch on YouTube. And we're like, we got two handsome guys, but we got Dr.
Really,
Who. Yeah, you want to check
shit.
check the YouTube.
This
out.
guy is good looking. Damn, that guy's good looking. And a voice, great voice.
Excellent voice.
All right, man.
Thank you, guys.
Thanks for listeners.
Thank you.
As
Keep doing what
always,
you're doing.
download, subscribe, review. Have a good one. Bye.